There's a whole host of questions related to antibiotic therapy. So some of the first order ones would be questions like, has group A strep developed a resistance to penicillin that would even require a clavulanic acid containing antibiotic?
Group A strep hasn't, but you can have beta-lactamase producing organisms that actually inactivate the penicillin, and so that it doesn't work for the strep.
So sort of normal flora that inactivates,
Yeah.
and so reduces the efficacy.
But no resistance specific for strep.
Okay, so one mechanistic question about the antibiotics is, why do antibiotics have an effect in pandas? If the antibodies are present, it seems like you would need to have the antibodies clear if that's the mediating biological mechanism in order for an antibiotic to have its efficacy by the mechanisms suggested, unless I suppose it would be through an immune modulating mechanism.
If we're talking about strep antibodies or like autoantibodies that are part of the theory?
The theory, I think the latter, yeah.
It's unclear because we haven't measured those over time in the antibiotic studies, so it may be that they are decreasing in time. My theory is that there's some immune modulation that's going on with the antibiotics. Specifically, azithromycin is one that's actually used to prevent like COPD, flare-ups, asthma flare-ups, because it does have immune modulation properties, and at the same time has the added benefit of protecting from recurring infections and exposures to infections. But we don't have any data on what's happening with the antibodies over the course of the treatment. My sense is that there's probably still some disconnect because some of the children are improving after 2 weeks. I would expect that the antibodies would have to run their natural course of typically 6 to 8 weeks, so there would still be some antibodies present, I would think.
Can I say something about antibodies?
Yeah.
It's a little bit off track, but I hope it's a little on track.
Okay.
In our clinic, there's a proportion of kids who do not demonstrate elevations in their ASO or anti-DNase-B titers, even though they've had a strep infection. Not that that's directly on target, but it reminded me to say it.
So I think a broader question is, how should a practicing clinician interpret, like today in this audience, interpret and apply findings from the antibiotics trials that you presented, Tanya? Does the evidence at this time support antibiotic therapy? If yes, in which patients?
Obviously, we need a larger trial. These were still small trials, but I think for an acute onset, severe, OCD, I think it's worth a try of an antibiotic, at least given it, 3 weeks to kind of see if you're getting an impact. The issue is like who's going to respond? I don't think we really know. My sense, and I have some duration of illness data, and not sure that's going to pan out, but many of the ones I've seen clinically, the sooner they were started on the antibiotic, the more likely they were to remit. That said, in these studies, and I didn't really emphasize it, probably about only 25% of these children remitted on azithromycin. So a lot of them still have residual symptoms that either need other immune modulation treatment like IVIG or steroids. And certainly all of my children that were still had residual OCD at the end of the study got CBT. So it's not a cure-all, and I think that it's one of the things that parents will need to hear is it's not a cure-all. You have to really add the other therapies in place for probably the majority of the kids.
Okay. So the argument at this point is it's reasonable. You're saying it's reasonable to try it for a limited period of time. Am I hearing also that if there's a response, you'd suggest then long-term treatment, or is it a limited time?
I think for a lot of them, my sense is that you really want to continue the treatment. If you get a good response and it's showing at like 2 to 3 weeks, because I think if you're getting no response at that point, you're probably not on the right track, or at least with the right antibiotic. And then I usually try for 2 or 3 months at the higher dose, and then try to move them to prophylactic doses. One of the things I find is that a high number of them, if you stop them too early, they flare up within a few days of stopping the antibiotic. So I try to take them a little bit longer out if they're having a good response, and then do a prophylactic dose of either the azithromycin or, one of the beta-lactam antibiotics.
We see patients who are on a cascading array of antibiotics.
I don't support that. I mean, I see a lot of children in my clinic that are very complex. I've had one that's come in on 5 different antimicrobials and did not look like he had any impact at all with his neuropsychiatric symptoms from any of them. I mean, it would be different if they were on 5 antimicrobials and maybe you had a dramatic response and you're not sure which one to get rid of. But with no response, I think that's pretty dangerous. And I've also seen a lot of people that do pulse dosing where they'll do like a short period of one antibiotic and then another period with another, just without any rhyme or reason. I mean, that may be some rhyme or reason in their mind, but not in any that I can think of. And I think that situation is obviously builds up, more risk to the child to have that many different antibiotics. Also, it probably increases risk for resistance to have short-term antibiotics go in and out of the course.
Okay. All right, so we can shift to Margot a little bit. Some questions about overall management. I think we're getting at some, what other additional alternative approaches could be considered. Questions such as exercise, herbal drops. One person pointed out, I have a patient who's being treated by a quote-unquote pan specialist who prescribes herbal drops. She also tests this child for yeast in the stool. Is there a reason for such treatment, such testing? And what about things like exercise to round out the approach?
Well, because I work in a university clinic, we really need to stay as close to as we can to evidence-supported therapy. So there's not a whole lot of evidence past what you've heard today, really. I was even thinking of bringing up the topic of NSAIDs because I've seen them be helpful. I'll say it that way.
There is a study for adults that NSAIDs help.
Oh, good. Thank
as,
goodness.
as adjunctive therapy for OCD.
Phew. So now herbal, we have said to people, some people try fish oil. That's not an herb, obviously, but turmeric, cinnamon, things that have anti-inflammatory properties. Oh, I read it last night in the New York Times that hot sauce can have anti-inflammatory effects, and this place here makes a lot of hot sauce. So maybe that would be something that you could use, but these are not evidence-based.
Right.
Oh, exercise. If you're in pain, sometimes people have joint pains. I think very moderate exercise, I guess, as tolerated.
Okay. I think this next question has to do with what might be on the surface, maybe what appears to be conflicting information. So the question is, why do you think that antipsychotic meds that lower dopamine levels don't work well in pandas if based on Dr. Cunningham tests that dopamine level is part of the problem? I think we've heard both that psychotropic medications are problematic, and we've also heard that they're recommended. And perhaps what we're talking about is different time points during the presentation. I think what I heard is in the very acute period, there's concern that psychotropic medications are going to potentiate symptoms, but that once things have plateaued, I think what I heard is that you're recommending their use. But maybe that can be clarified and maybe address mechanistically why there might be some different mechanism suggested if there's a dopamine modulation involved.
One of the things I think they do respond to the medications, and I agree in the acute phase, sometimes they're just sort of friable, I guess is the lack of a better word. And I think one of the issues is a lot of the antipsychotics that we use have a lot of serotonergic function, and I think it leads to that kind of activation that we think the children are much more prone to have. I think after obviously if you have a child that's, bolting out of the house and is being self-injurious, you have to try something, that may work faster than even the immune modulating treatments. And I always advise just go the lowest dose possible, because I think they are more sensitive, and then just, tiptoe up to it as they tolerate it without activation. And I think a lot of the children will do okay with that. You just can't start them like a neurotypical child that's not had any issues other than they're presenting with, behavior or aggression or psychosis. I mean, I guess our kids do that too, but they tolerate much lower doses without, and that's true with SSRIs. I think it must be the serotonergic function. We haven't really tried Haldol or something that's less serotonergic in these children.
The question is how low to start with?
Well, most of the children that I'm seeing are very small children, like 5 to 7 years old, and if I'm going to use one of those medications, you might use something like 0.125 Risperdal, which is pretty small, and go up as tolerated. Benzodiazepines, I think if you don't get any of the sort of paradoxical reactions, I think is a pretty good way to start as well. One of the ones that I don't see the behavioral activation to is, especially if you need some sleep, is like clonidine, low dose clonidine at night to help with the sleep, and that often will also have a little bit of calming effect. And Benadryl I think is fine, especially in our kids a lot of them have allergies anyway. So
That actually partially addressed one of the other questions that was asked to you and Dr. Tiedemann about other soporific therapies like clonidine, zolpidem, gabapentin. I suspect the answer is try it low dose, see if it works. There's not going to be a single agent that's going to, everybody's going to respond to.
I would say exactly that.
Yeah. There's been, Tanya, you alluded to the idea that we've known for some time that antibiotics have psychotropic activities. And so there's a resurgence of interest in drugs like cycloserine. Have you seen any evidence for their efficacy in patients with PANS?
No. The use of D-cycloserine in most of the anxiety studies has been incredibly, almost homeopathic doses that are, affect the extinction learning in conjunction with cognitive behavioral therapy. They're far below the typical antibiotic doses used like for TB. So I don't know, I would say not.
Question for you. The question is, do you see acute neuropsychiatric episodes of PANS patients? I think the question is while they're being treated. Did I get that correct? Yes. Yes. While they're being treated. So in the setting, like known PANS patients, do they come in with acute exacerbations? Have they risen to I guess, our attention on the inpatient side?
Not usually. Usually the case because most of the what we call PANS patient goes to PANS experts. So usually what we will see as a child neurologist will be question whether what does my child have, the diagnosis. So being a child neurologist, we always have a broader approach. Look at it, not just looking at the PANS or PANDAS point of view, just looking at the whole spectrum. It could be any type of the autoimmune neurological disorders, and then do the differential diagnosis and evaluations accordingly. So if you ask me, come up with a PANS diagnosis and then do they come to you in the middle of the exacerbation? No, they don't. But I've seen hundreds of many other kids coming with the acute neurological and psychiatric symptoms, the movement disorders, and not having the exact diagnosis, and then do the evaluations. We do see a lot.
The next question is really, I think, for Margot and Tanya. So if a patient that has autism, or in a previous era had PDD-NOS, and which is comorbid with Tourette syndrome, et cetera, has your ability to discern an exacerbation that is PANS versus an exacerbation of autism per se. Have you been down that path before where you've had to sort out those issues? And does it fall neatly, or is it a struggle?
I would say it's murkier than the regular PANS for sure. I've seen several of the children that have regressions, and some of them seem pretty convincing that they might have been strep triggered and have the classic, OCD symptoms. Kids with autism can have OCD that is sometimes tricky to distinguish from restrictive and repetitive behavior, but they can have classic OCD. They can also have classic looking tics. And I've seen some of those respond very well to immune therapies. But again, I think because, they already have such developmental issues, previously, if you see that significant regression, I also worry that we're missing metabolic, genetic, mitochondrial, and so forth disorders that you might not expect to be as much of an issue with a kid presenting without ASD. So I think you have to worry more about the differential diagnosis.
Okay, so I think the last question for this panel is a hard one, and there's a couple people who have very similar ideas. So it appears one very consistent feature of PANS and PANDAS is acute onset of some type of mental health, psychiatric symptom, even more than the movement issues. Doesn't this also occur at times in primary psychiatric disease, or does this acute presentation always suggest a secondary cause and mandate a more extensive evaluation? So can't bipolar disease or depression or you name the Axis 1 diagnosis present in an explosive fashion that's not necessarily mediated in an autoimmune fashion?
I would say it's the issue of the context of the presentation, and most of the children that I'm seeing are 5, 6, 7 years old, and they're acutely ill, severe OCD, they're depressed, suicidal, not eating, have huge rages, or not sleeping. And I really can't think of many pediatric onset disorders that would present quite like that. The area where I get a little bit more concerned and cautious is when I have a 13, 14, 15-year-old that presents that way, and am I looking at, the typical presentation of schizophrenia, bipolar, and so forth. And I think, you do the assessment, you look for the triggers, you look for any kind of autoimmune, evidence, and then treat accordingly.
Okay, so thank you all. I'm going to shift the panel, so thanks very much.